I think in the very short span of time, Kalyan Saja needs no introduction in the interventional arena in India. He has made a huge mark. Anybody who is in that neurovascular clinician group will know that the number of cases he's doing, and he's a pioneer in the radial route. So without wasting time, I would like to welcome. Most of the people who are in the meeting are actually people who are doing interventions. Most of them are fellows. I would like to introduce Bobby, who is the head in Aster. Dr. Vivek, I think he's here. Then Dr. Anil Kumar, Dr. Muthukumaran, most of them are fellows in Rajagiri Hospital. So everybody is eagerly waiting for your talk on the radial route. So shall we start?
Sure, Dr. G. Hi guys, very nice meeting you all. So so my training is mostly in the United States. I got my both intervention neurology, neurocrit, and endovascular training in Philadelphia. I was one of the first radial fellows, first batch of the radial fellows from my program. So setting the stage, as soon as I moved back to Guntur and during the pandemic, we got the cath lab, and our second case was this. We did a diagnostic angiogram as the first case, and the second case was this. It was a 45-year-old, history of multiple vascular risk factors and peripheral arterial disease, coming at 1 a.m. He did not have any pulse on the right or left femoral. Fortunately, my protocol was prepare the right radial artery and right femoral artery for all strokes. And CT angio showed a type 3 bovine arch. And for these bovine type of arches, we found radial to be much, much easier. So we went to right radial. It was a tandem occlusion. We cleared the ICA and then cleared the MCA and was sticky 2B. And patient recovered very well. Also, I did not have angioseals as the closure devices, as I just started my program here. And then, so coming to why we need to, or why to consider switching to radial, I will go over why we consider switching, and then some patient selection and some techniques, some tools. I was trained with different set of tools, but after I came here, I adapted to the setting and found my own catheters, which might be better for Indian setting, and some examples on catheterization of great vessels via the radial artery, and how to take even the big shuttles, the 088 guides into the ICA, the right ICA or the left ICA. Some case examples, closure techniques, some radial artery variants where you might need to avoid radial artery access, and then conclusions. So this was one of the bigger trails. They compared the rival trail, went from 2006 to 2010, compared transradial to transfemoral access, and there was definitely some mortality benefit with that. And there was significantly lower hematoma and pseudoaneurysm that required closure in the radial artery. And there was lower rate of vascular risk factors and vascular complications. And that, it points us towards maybe it's better to use radial approach for most of our cases. And this was one of the larger trails, which had 8,000 patients. And the major access bleeding was 3 times higher in the femoral group compared to the radial group. And it also had a mortality benefit with the radial route. Similar other systemic reviews and meta-analysis, most of them are from the cardiac world. This meta-analysis had about 40,000 patients, and access complications, like shown before, were 3 times higher in the femoral access route. And there was definitely some mortality benefit as well. So when you are trying initially in the initial phases to switch to radial artery route, some of the common headwinds are, if you are sharing your lab with the cardiologist, they'd be on your neck, breathing down your neck, if the access is taking much longer, if the cases are taking much longer. They can be somewhat longer procedures initially, but right now, once with practice, you keep practicing, you keep doing cases. Right now, I can finish up my angiogram, diagnostic angiogram, without selecting ECICA, just non-selective angiogram within like 5 minutes. And people say you need more contrast, more radiation. But by now, I found we need almost less contrast compared to femoral, or same amount of contrast and same amount of radiation. And some of the other excuses are, like I can't use my favorite catheter, either a Neuron Max or Bellast. And I'll show you some examples where we use it very frequently, very commonly on a daily basis. And then radial artery occlusion, how to prevent that. If you occlude the radial artery, you're losing access. Um, and some others told me, our radial arteries are smaller and might be harder to switch, but I did not have a lot of problems with the smaller arteries as well. And some others say, if you're going to admit the patient, we are going to watch the patient for 24 hours anyway. So why radial? Why can't we do femoral? And we published several papers and also a book on the radial artery. And our conclusions were radial artery catheterization is very safe and a very durable alternative for neurointerventions, and the treatments. Has very low rate of complications. On the whole, patients like and prefer radial transradial access compared to the transfemoral access. This was our from our paper. In our Indian setting, I think radial procedure seems to be the women actually don't put we just drape them with the gown and then just prepare. I stopped preparing femorals for all my diagnostics. We prepared the right radial and then the right snuff box and the left snuff box for all my diagnostics. This was one of our patients after a carotid stent. His hemodynamics was pretty good, so we let him do whatever he wants. And we also did all of our robotic diagnostic angios and even robotic carotid stents via the radial only. I was one of the first fellows to be trained with the robot in the US. And learning curve, you start with diagnostic angiograms. Dr. Gigi was telling me he wants to start with diagnostic angiograms. I'd recommend starting with the follow-up angiograms, the one you did coiling or the stent on, they come back to you in 6 months or 1 year. Start with those angiograms, especially in people who are sharing their lab with cardiology, so that it gets easier, it gets done quickly, and then you'll develop some confidence. Try to use an ultrasound, at least initially, if you're not very confident. That will reduce the number of errors and reduce the radial spasm rate. But once you're comfortable, you don't even need an ultrasound. Especially when you're doing snuff box initially, better to start with ultrasound. And then this is a good paper on how to set up the room for diagnostic angiography. I'll show you some of that. The main tools are just any. I was telling, use Merit slender sheets because the thickness of the sheath is smaller, and the 5 French sheath is the same size as the 4 French compared to other companies. But then now I'm using just regular the Teramo radial short sheets. I was using initially the steel needle, but now I switched back to Gelco to make it uniform across all the types of accesses. The main catheter I use is 5 French Simmons from the Teramo. It's called GlideCath Simmons. That is the softest and is best used. And across India, I reuse most of my material to keep the costs low. And I've been using the Sims for many times. These come in like a single piece, so they don't break. The multicolored ones from Merit and multicolored ones from from Penumbra, they break a lot. Hello. Your voice is very lagging. So the vendor is Teramo Simmons. Is that what you're asking? Okay, I'll move on. So
everyone to type in the questions, if they want.
Sure, that'll be great. And 5 French Simmons is the main catheter. Sim 1 I rarely use it. And SIM3, it's used to selectively catheterize the left port from the right radial. I use it very rarely. I actually don't have it in my lab because I couldn't find it here. And most of I spoke with some people from Delhi who were doing interventions, and they were telling me the people are taller there, so they're using 125 centimeters. But in my state, at least, I'm only using 100 centimeters. Even for tall people, it works fine. Even in the US, I was actually using 100 centimeters, and it worked fine. Uh, and then Bernstein, the stiff Bernstein, should also be carried in your lab whenever you want to switch to radial in some kind of cases, like the bovine arches or some other type of tough pseudo bovine arches. You need them. I'll show you some examples. And coming to the bigger guides, Cook Shuttle, the 90 centimeters or 100 centimeters is still my favorite. It's very cheap and you can reuse it multiple times, even via the radial. And it offers a good support, like proximal support. You can't go too distal with it. There are some limitations to it. You just have to be careful with that. But otherwise, I think it's one of the better catheters for better guides, the large guides for radial. And Bellast, we actually wrote a paper on the Bellast. It works very well for radial. The Infinity, Stryker Infinity also works very well. Neuron Max, we used to have a lot of radial artery spasms in the US, but here I'm not seeing a lot of that complication, and we are using Neuron Max without issues. The concept of this slender is, the Merit Slender 5 French is the same as same size as same size as 4 French when compared to the other manufacturers. So they make the wall thin, and you still have enough lumen to use it. If you guys don't care about the cost, I think, and even then the cost is not too way off. I think Merit sheets, the Merit Prelude sheets, are one of the better sheets for radial, especially if you're going to start out initially. I'd recommend using that. But I've been using Thermo without issues. Yeah. Okay. And coming to the the table setup for radial boards, people have come up with multiple kind of variations, expensive boards. But in my setting, we should mute someone.
I request everyone to mute the phones, the microphones, please. But I think your microphone is not muted. Hello.
Okay. Okay.
Please mute the microphones.
So the goal for setting up a table is to arm and leg. There will be a lot of blood pooling up and falling on your legs and other stuff. So the goal is to make it like a stable, straight platform, like that. And let's run the video. That's how it's supposed to look. That's how it was in the US. We used to have a separate small table for the contrast and the saline, but here I'm actually using it at the bottom of the table. These are the ones I actually went to a tire shop and asked that guy to, I think it was like tire or sofa shop, and I asked this guy to make these cushions. These are very comfortable for the patients. If you have this angle, they can just place their hand on top of it, and then the hand and the legs actually come to the same height almost, so that you'll have a uniform platform there. And you guys probably know this. So this small piece comes with the Neuron Max or the Bellast. This is useful, when you are trying to fit a 125 centimeter SIM through the Neuron Max, the 100 centimeter Neuron Max. To shape it and to use it, actually, you need this connector at the bottom of the large guide. And patient selection, radial artery might have less radiation to fetus in pregnant patients. It might be better in pregnant patients if you really have to do an angiogram. For people with large body habitus where you can't feel the femoral or where closure might be difficult, um, you might that might be an ideal patient. For bovine or type 2, type 3 arches, the radial axis works very smoothly. It's as if the arch is made for radial in some cases. In people with prior iliac stenting or bypass, femoral occlusions from peripheral artery disease, people who are on multiple antiplatelets or anticoagulants are at very high bleeding risk. You don't want to risk the femoral axis. You can always go radial. One of the contraindications, maybe some soft contraindication, is if you're considering a future AV fistula for dialysis or for graft, then if you occlude the radial artery, probably you can't. That might be a problem. But we have come around. We have used some workarounds, like using the snuff box that reduces the radial artery occlusions to practically like less than 1% or something. And then you can always open the radial artery, open an occluded radial artery from the femoral if you needed to, like using balloon angioplasties. And people have published this multiple times. You guys don't need to do ALICE or Barbeau testing. We used to do that in our lab when we started initially, but then American Heart Association issued a statement in circulation saying these are just historical tests and you don't really need to do that. And I stopped doing it like 3-4 years back. That's the basic anatomy: the radial artery, ulnar artery. There are two arcades, superficial and deep arcades. The superficial arcade you can actually access on the radial side. That's the snuff box. And of course, there are multiple variants like accessory radial arteries, where it'll be really hard to use it for bigger procedures. And this is the use of ultrasound. You can see the radial artery. You just have to puncture it using the ultrasound. And when you start using ultrasound in the initial phases, when you're using the radial artery, that reduces the number of punctures. It keeps patient comfortable. You will start slowly gaining confidence. This is the same concept regarding the sheath and the guide. I'll actually show you some examples where you'll understand this better. Some preparation tips. I apply some EMLA cream like 15 minutes before the procedure. And after that, I use betadine and sterilize it. And then use 2 cc of lidocaine to infiltrate the periarterial tissue. I stopped using an ultrasound. Now I'm just just palpate the pulse and then use Gelco needle. You can also use steel needles, whichever works for you. Steel needles are a little bit better in that you can change the angle, change the. I'd recommend actually start to use steel needles. I think they might be a little bit expensive, but still they're like around 75 rupees or something. My cocktail is I don't use verapamil. I just use nitroglycerin and diltiazem and 2,000 units of heparin. Even in patients with ruptured aneurysms or subarachnoid hemorrhages, I think the heparin, when you give it arterially, just stays locally to prevent radial artery occlusions. And once you puncture and get the sheath in, always get a radial run. It helps in planning. Like if you see severe vasospasm, do some additional cocktail. If you see accessory radial arteries, if you see accessory radials, you can use smaller catheter. Okay. All right. And we published a lot on the snuff box access as well. And this seems to be much comfortable with, like patients are much more comfortable and you're actually preserving the radial artery for the next procedure. So we were doing angiograms with the snuff box and then using the radial the next day or so. Someone comes in with subarachnoid hemorrhage, we use the snuff box to do the angiogram, plan the procedure, and go radial the next day. That's the snuff box access. It's very simple. Like I said, I stopped using the ultrasound to gain access. So you just palpate it and then slowly introduce the needle at this maximum pulsation. And then this was a merit sheath, so even the wire is a little bit special. It goes in very easily. Once that is done,
Bring in the stuff box.
you'll use the sheath. These are a little bit longer sheets, and they can actually sometimes they go all the way close to the brachial. But since the access point is close to the radial, that will help you a lot in preventing spasms, taking much bigger. This was a 6 French sheet. I think this was for an intervention for an aneurysm coiling or something. Anyway, and if you see spasm, you can give some more cocktail without the heparin. Just be cognizant of the heparin. Sometimes, if you give 2 or 3 cocktails, it'll be like 7,500 units of heparin. You can warm your saline and then have the. I always connect my sheets to the flush to prevent other complications like radial artery occlusions. And you can give some sedation to reduce the spasm. And if the spasm becomes so hard that you're not able to pull the catheter out, you can give some Versed and some fentanyl for sedation so that the patients will relax and you can get the catheter out quickly. Ipsilateral, blood pressure cuff compression can also help in dilating the artery. And these are some cases, difficult cases where you need to don't yank the catheter out, or you just had to be careful about avulsions. I had one avulsion when I think I went through the accessory radial. I did not do a prior diagnostic, so it was a direct intervention for a carotid stent. And after we actually used the accessory radial and then finished the stenting, and while we are pulling out, we realized the catheter was stuck. We slowly got it out, and then the catheter got stuck in the radial in the forearm, and then we had to call the vascular surgeon and said, well, I see 2 radial arteries. That means that we went through the accessory radial. You just have to be careful about the accessory radials, not to take bigger catheters in. And here, like I said, I'm using Gelco needles now, but I recommend starting with a steel needle. And Merit hydrophilic sheath, I think it's the best sheath for radial artery. It's called Prelude sheath. My main workhorse catheter is SIM2, but you always have to, this is the Terumo SIM2, Terumo GlideCath Simmons. But you always have to have a Berenstein, Cordis Berenstein, and a Cordis SIM1 ready, just in case. Don't open them, but just if you need it, you need it. I'll show you some examples where we need it. Coming to the shaping of the SIM, you can shape it in the descending aorta, which is the easiest and more common. You can shape in the ascending aorta. That means you hit the aortic wall with the wire, and then the wire takes a J shape, and you just follow the catheter, follow the wire, follow over the wire with the catheter, and remove the wire, and then the catheter is shaped in the SIM shape. Sometimes when you're doing that, it can go into the left ventricle, and you'll see changes on the EKG. Then quickly pull it back, and it should be fine. You can always shape it in the right subclavian, in the right vertebral artery, and push it down. So these are the first one here. The first example shows the catheter coming from the right side, from the right radial, and going into the right vertebral. So now you can do a selective vertebral run. And after this, if you just push it down and twist it, it can maintain the SIM shape. And without a wire, you can actually access the right and left carotids, in the left vertebral. On the second example here, in the first image itself, we are coming from the left radial. For the left radial, you always have to hit the aortic wall with the wire and then follow the catheter on top of the wire. I think that might be the only way to shape the catheter consistently when coming from the left radial. And then the second picture here on the right side, this is more commonly done, more easier way to shape the SIM. You just have to go close to the aorta, to the descending aorta, and then push the SIM, and it will take the shape very easily. Yeah, here the first image shows shaping from in the heart across the aortic wall, hitting the aortic wall and coming up. And the second image shows here shaping in the descending aorta and how to access the left vertebral. So you have to maintain the J shape when you're trying to access the left vertebral. I actually did some fluoro saves and I'll show it to them, show it to you. And the way to access the left carotid is still maintain the J shape and then untwist it, and it will just fall into place. And these are some of the, this is a bovine arch. This is what I call a bovine arch on the first image. So you are using, here you're not using a sim, you're actually using the stiff cordis Berenstein to hook the left carotid and then send the wire. And then on top of the wire, you can send whichever is your big catheter, the Bellast or the Cook shuttle. Similar way from the left side, when you're coming from the left side, you need a bigger axis. You can hook the Berenstein, you can hook the right carotid with the Berenstein and go all the way up with the big catheter. You really can't access the left carotid with a big catheter from the left side. But I have done several embolizations, MMA embolizations or other embolizations from the left radial into the left carotid, mainly because for embolization you don't need a big catheter, you just need a 5 French or a 6 French diagnostic catheter. And some videos here I'll show you. So here I didn't even shape the catheter. The wire directly went into the right carotid via the and then I followed the wire with the Berenstein, and on top of the Berenstein you can actually send the bigger catheter, the Cook shuttle or the whichever is your large guide, favorite large guide. Once you're up in the place, you remove the wire and then always do runs. The second example here, same thing, wire directly into the right carotid artery. Here we actually shaped the wire and then it went into the right carotid. You slowly, gently take it up and then follow it with the catheter. And the bovine arches, the wire actually directly goes into the left carotid artery without any shaping. You don't need to shape the catheter or anything. The wire directly goes in, and you just follow that with a a diagnostic catheter for some support. And on top of the diagnostic catheter, you can telescope your bigger catheters. When you start out initially, the left vertebral artery will be very more difficult to catheterize. In some cases, if you don't have a SIM3, you probably cannot access the left vertebral. In those cases, what you can do is just keep the catheter in the subclavian and inflate a cuff on the left arm, and then do some contrast injections. And that, that selectively goes into the wort anyway. And you'll get the information that you need. The left ICA can also be a little bit harder when you start initially, but the right wort and the right ICA are easiest. So when you're selecting cases initially for the follow-up angiograms, those might be better to boost up your confidence. In our carotid stent papers, there was like 30% failure or conversion rate when you're going into the left carotid stenosis. But this was like a initial paper, and now my failure rate is like less than 5%, even for the left carotids. But when it fails, there's no point in going radial. You'll have to go through the femoral at that point, or you can use the left radial anyway. And I actually started doing this all my carotid stents via the snuff box. I don't have a lot of carotid numbers. I only did like about 15 in the last 2 months. So we are accessing the snuff box with a 6 French sheath, and then we use an Envoy or a Fubuki. Envoy has a very good reusable value. Similarly, the same with Fubuki. If you guys don't care about expense, you can always use Benchmark. But Envoy has a good proximal support. And then you use a selection catheter. I'll show you an example where we use a selection catheter and send the 6 French sheath all the way up into the carotid. One wire to have in your lab is the glide wire Advantage. It comes from Terumo. It's the same thing as the glide wire. The distal end is the same as the glide wire, but the proximal, it will have a really good support. And that's very useful when you're doing radial artery procedures, either diagnostics or even like big interventions. And if you guys are thinking of switching to radials for carotids, only I try to keep my profile low, so I use a 6 French guide, the 071 guide, and the 071 can only deliver precise 6, 7, 8 millimeter stents and wall stents. For 9 millimeter, again, you'll need a bigger 088 guide sheath. Like about 80% of my 75 to 80% of my mechanical thrombectomies are done via radial. So we use a 7 French radial sheath. That when you use a 7 French radial sheath, what you have to do is you have to exchange the sheath to a guide catheter. So you can use a 6 French sheath and then exchange to a guide catheter. But when you use a 6 French, you have to give a small incision. I never give incisions to my radials because it has a little bit higher complications. So what we do is we use a 7 French radial sheath to dilate it even to a bigger size, and then exchange the radial sheath over a Glide Advantage or a Glide Wire to a Neuron Max or Bellast or whatever you use for strokes. And then through that, you go with a 125 centimeters Simmons, like the Penumbra Sim, or you can even make your own sim. I actually make my own sims using the MP2, using steam shaping, and then I'm using them. So the combination of Cook shuttle and or Bellast and the 125 centimeters, that's my favorite combination. There are some new entrants like the Walrus balloon guide and then the wrist catheter, which many of my friends in the US are actually using for radial access. Once you have the guide position in the ICA, the rest of the procedure is same as the femoral. For example, I think this was kind of like almost like a pseudo bovine arch, where we accessed it with a wire. We went all the way into the ICA, high up into the ICA, and then use the Bellast. You see the Bellast, how the shape, the top justice, it's taking very easily. Once you go up there, you do the thrombectomy or other intervention as needed. To do a thrombectomy, like if you're getting CT angios at your place, just discuss with your radiology tech to get the CT angio till the arch. Many of, at least here in my place in Guntur, people don't get CT angio of the neck. They only get MR angio of the head. So that has been a little bit impediment. I don't want to waste some more contrast and get a CT angio and then shift to the cath lab. I just do a non-contrast CT and then shift them to the cath lab. But if you have the neck imaging, that will give you an idea of what kind of arch it is. If it's a type 2 or type 3 bovine arch and you need to go to the left side, radial is always better. And of course, like for posterior circulation, I've been burned many times. I start with the right radial, go up, and then realize the right vert is non-dominant. We can still do thrombectomy from that, but then I'd have preferred doing it from the bigger vertebral artery. I think in strokes, Dr. Gigi was talking about the stroke conference you guys will be having. I'll be happy to attend that. I'll discuss all my techniques for radial stroke interventions at that point. I know there is some discussion with balloon guides, but we actually, when there was this flow gate balloon, we actually were using the 7 French sheath and using the flow gate for some cases. But yeah, the flow gate is smaller. So I stopped using balloon guides for strokes. One, they're too expensive. And there's always some argument between balloon guide users and non-balloon guide users. For radials, especially the materials that we have, I don't think balloon guide is possible other than the Walrus guide, which we don't have in India. Some techniques, if the catheter is herniating from the left side, is what we call a millimeter inching. So we move the catheter, the diagnostic millimeter by millimeter, and slowly advance the guide over it. Like I said before, glide wire advantage. It's called a glide wire advantage, Terumo glide wire advantage. That's the best radial wire you can use. Exchanging over the other wires, exchanging the catheter, the diagnostic catheter for a guide catheter, that's not very elegant, and that can cause complications like thrombi and embolisms. So always better to telescope. and a six French SIM diagnostic catheter or selection catheter can offer even better support. I haven't found it in India, but then you can always shape a MP2 SIM into a MP2 into a SIM shape. Left radial, I use it commonly if I don't find the right radial, or if I want to save the right snuff box for a carotid stent, and I want to do a diagnostic. I sometimes go through the left radial and do the angiogram, and then the next day or something, I leave the snuff box intact for the procedure. For pipelines and other procedure, the guide needs to be very high up. I think Ballast is the clear winner there. Some more examples here. The shaping of the wire in the descending arch. And that's what we are showing here. Okay. Oops, sorry, 1 second. It's the right vertebral. I think for some reason we were not able to access the right side, so we came from the left side and we injected the right side. In this case, this was a occluded right. The wire was going, but the catheter was not going. That's what this video was showing. I think it's occluded at the right subclavian. So then we came to the left, and then that's what it's showing. It's occluded when we did the angiogram. It's occluded subclavian. And we finished the angiogram from that side. Some more examples. See, this is how you go into the vertebral artery. You send the catheter up, and then you can use the same shape to actually push down. And then the second video here shows how you shape. This is like a little bit more tortuous, more difficult case, but still we were able to shape the SIM. Oops. I'll go back a couple slides back so you can. So this was a case of bovine arch, pseudo bovine arch, because the catheter is still not hooked into the left ICA, but still we were using the Cordis Berenstein. We were able to provide a good support for the wire to go up, and once the stiff glide advantage is up, you can always send whichever catheter, whichever guide you want on top of that. These are some tough cases of. This is a tough case of. Tough arch. We needed to do carotid stenting in this case, and the wire we used here was a 038 wire. Usually we use 035 wires for diagnostics, but 038 wire, it's the same Glide Terumo 038, is a very good catheter. This video shows us not going into the arch at all because it was very tortuous. So what we had to do was just get into the carotid using a road map. And once we are in the right ICA, we went up all the way in and finished the case. And this is an example of how to access the left vertebral artery from the right side. You just have to twist and untwist. If you have a SIM3, it becomes very easy, but I was not able to find SIM3. So, and for the few cases that we do, that we need SIM3, I didn't find it financially feasible, so we just keep doing that. Similar way, some more examples on how to access the left vertebral from the right radial. This is one of the accessing the left vert is one of the more difficult maneuvers. Another snuff box carotid stent case where we just use the wire. Just use the glide wire to go all the way up with the Fubuki, I think. And then here we are seeing delivering the carotid stent. And then you always have this aortic origin verts. So here the vert was coming just very close to the subclavian, and we had a difficult time, but still we were able to access it and do a selective angiogram very well. Another example, so we did a roadmap, we did a run, and then we twist and untwist it. You see how it kind of hooks into place into the left vert, twist and untwist, and then it very easily well, it's not easy, but with practice, it gets easy. It hooks into the leftward. Another example, I think this was an aortic arch origin leftward. Once that is done, once that is in place, we go a little bit higher up and then do the selective run and go from there. This was our case. This was our paper regarding Bellas. We actually compared Bellas to Fubuki at the same time. There is a Fubuki Asahi made by Asahi Fubuki 088 or 090 long guiding sheath. We found that Bellast is much better. Even when compared to the Cook, it's much better in taking the torch Ostis. We also wrote a paper on the left radial axis approach. This was initially when we were using incisions for the sheets, but we actually stopped using incisions. I don't think we should be using incisions for getting the sheath in. We just have to dilate the radial artery and go in with the sheath. Left radial and left softbox is an underutilized tool. For any type of intervention from the radial, I don't think we should be using incision. If you need to get your long sheath, the 088 sheath in, you just have to exchange the 7 French radial sheath for a 088. That avoids using the incision and reduces the complications. This was our book we wrote regarding radial axis for neurointervention. It's available on Amazon. It's actually a little bit outdated because we have evolved since we wrote that book like some 2 years ago. But I think it has most of the basics. Most of these radial bands, snuffbox bands, are available in the market, and they cost about like 1,000 rupees or something. We stopped using this. We actually just use, just the whatever the technicians use, the cotton roll and then the tight bandage. For thrombectomies and 088 guides, we leave the dressing for 1 hour, and after that it should be fine. For people who get TPA, we just do it for 2 hours, and you don't see any hematomas or other nonsense with even post TPA, because you see the radial artery, it's just there. So unlike the femoral artery, you can simultaneously compress the ulnar artery while you are closing the radial. That actually is helpful in preventing radial artery occlusions. Most of the radial artery occlusion studies, they showed when you're cross-compressing, when you're simultaneously compressing the ulnar artery, that reduces the rate of radial artery occlusions. But then especially when you're using long guides, but then when you use the snuff box, that reduces the radial artery occlusions to even lower rates. So that's how you close. So you remove the sheath. If you want it to be very neat, you just put a cotton pledget under the sheath and then put the radial, whatever type of radial band you have. And most of these, you inject air into the radial band. And then once you inflate the band, you remove the sheath. And then after that, remove the cotton Q-tip. Similar way, how to close the snuff box. This is snuff box closure. Remove the sheath, apply the band on top of the sheath, and then once you inflate the sheath, remove the sheath. Or inflate the band, you remove the sheath. This is my current setup. This is how I'm doing it. So I prepare the right snuff box and left snuff box. People don't remove their pants. People don't remove their saris for diagnostic angiograms. They just come in with their sari or with whatever they're wearing. We just prepare I don't even shave the radial artery axis side. We just throw a drape over the right snuff box and the left snuff box. If the right snuff box doesn't work, the left snuff box works. If that doesn't work, then we go to the right radial. And always start out with an ultrasound. That will help you boost your confidence. Here, actually, in the ultrasound, you are able to see the radial artery there. This is an expensive ultrasound, but then I use a very cheap ultrasound in my real world practice. These are some unfavorable left carotid takeoffs. In these cases, initially you won't be able to access these arteries very well. But then if you use a Bellast, if you use a glide wire advantage, and you use this what we call a millimeter inching, so millimeter by millimeter, you send up the diagnostic catheter sometimes the 6 French diagnostic catheter actually helps in providing that support. On top of that, you can slowly send the large guide up. One example here. This is an unfavorable takeoff. No matter, actually, the shape of the catheter, you need it to be in the right shape for this to work. This was very unfavorable shape of the catheter itself because of the anatomy. And then I'm trying to find the right shape. This shape is ideal because it won't herniate. Now you send, it's almost like pseudo bovine shape. Now you send the wire up, and then now you go on top of the wire. This was an exchange that we are doing because we didn't have a 125 centimeters. We exchanged it to a Fubuki. I think this was a carotid stent that we did. And again, radial, it's not a religion, it's only a tool. There are cases where you really can't use the right radial. For example, what we call lusoria or ARSA, aberrant right subclavian artery, where the subclavian artery goes all the way into the descending. In those cases, it's really hard to use the right radial. But then in those cases, that's the reason I prepare the left radial as well, left snuff box as well at the same time. And in those cases, you can just use the left snuff box for diagnostics, especially, and for some interventions like embolizations. But at the end of the day, if you need femoral, you need femoral. I try to avoid it most of the times. In these 3 years or 2.5 years, I only did one femoral. I only used one femoral axis for diagnostic angiogram, and even that was at the outside lab where there were no neurotechs, and I was like tired at the end of the day. I didn't want to teach them everything, so I said, "Yeah, that's fine. Prepare femoral." But otherwise, I've been getting away with using radials and snuff boxes, either the right or the left, and it's working fine for me. And with the current technology and devices, we come a long way. There are some catheters, I think Medtronic might be launching, called the wrist catheter. My friends tell me they're really good in through the radial. They've been doing strokes through the radial and everything. They're working really well. I've been waiting to use them. This was an interesting case. So I actually shaped these catheters, because I do free of cost thrombectomies and I do low cost aneurysm coilings and everything. I need to keep the cost of my material very low. So for that, if I use a Penumbra Simmons 125 centimeters, it's going to cost me like 25,000 rupees or something, right? So I use this MP2. This is a MP2 cardiac catheter. It's a 5 French. I shaped it like 1 year back in anticipation of using it for a stroke, but I haven't used it. It sat on my shelf. I haven't really used it because I'm not sure why. But then we had this case where we tried exchanging the 5 French for a large guide, and then it kept herniating, and the patient did not have a femoral artery. There was like peripheral arterial disease. There was no pulse there. Even with the ultrasound, I couldn't see anything. So I thought, for some of the technicians said, "Do you want to use this MP that we shaped? That we steam shaped it actually." Oops. Oh, there was no video. Have to wait. Yeah. So this is the MP that's taking the shape. We could have given a little bit more shape to the sim, like the sim, but I think it's been 1 year and the catheter lost its shape a little bit. Still, we were able to access the left carotid. Now here we twist it into that V shape, and then on top of that V shape, we advance the glide advantage, and on top of that, we are getting this big guide all the way into place. See how easily it goes in. After this case, this was a recent case. After this case, I got confidence that I don't need the Penumbra sim. I can probably shape a 6 French MP for even better support. I should try that at some point. And there was an article published in JNIS where they were using a single catheter for carotid stent. They were using the, I think, radial axis, not snuff box, and then they were using a 6 French sheath and a 6 French sim, and then using it to access either the right or the left radial, and right or the left carotid, and placing the stent in. I tried to get it on the market here. I couldn't really find the 6 French single colored catheters in Simmons shape. So I probably will try shaping a MP2 or something, and then I'll try that. And there are these variants called radial loops, where it's might be difficult for these cases to go through. But if you use a glide wire advantage, these just straighten by themselves. And there was a recent publication where people actually straightened the radial loop manually with their hand from the outside, and that worked fine. Be careful of the variants. This is an accessory radial artery. Many times it works fine because we were doing the strokes without. So when we do a stroke, time is of the essence. So we don't take a femoral run or a radial run when you are going up all the way. So in those cases, this was a accessory radial. We didn't even realize it was an accessory radial. We went all the way, did the stroke, and then came back. The patient incidentally had an aneurysm, and a few months down the line, we went back in to do a diagnostic angiogram, and we were surprised to see, oh, is this the accessory radial that we did the stroke through? So many times it should be okay, but then I also had, like I said, an avulsion of the accessory radial case. Patient did fine. He didn't. He had some pain for a couple of days, but and he does have his radial ulnar artery. The accessory radial, the catheter stuck in the accessory radial was removed en piece by the vascular surgeon. But that's one of the very few complications I had via the radial route. This was in the last 3 years. These are the small calibers. Look at this caliber of the accessory radial. It's joining at the subclavian. In this case, we were not even able to advance the diagnostic catheter. We even tried a 4 French, but then, it wouldn't go through because of the tight spasm. So we switched the case to left snuff box and finished the case. This was one more complication I had. Patient it was an aspirin and brilliant. This was the avulsion case that I was talking about. He had some swelling for a few days. We applied some thrombophobe and gave some painkillers. He was fine. Of course, we don't have 125s, or we actually requested Penumbra to give us some specially designed 150 or 140 centimeter Simmons too. And we did some spinal angiogram cases with that while I was in the fellowship. But then after coming here, I haven't tried that. Maybe we can steam shape a SIM or something, steam shape a MP, like a large, like 150 centimeter catheter into a SIM shape. And we can definitely try doing these spinal angiograms. This was a spinal angiogram from the radial axis. This was my case, assisting Dr. Jabor. So you shaped it in the descending and go all the way down, and then do all the, flick the catheter into place into the artery, and then complete the whole radial angiogram. That. We were even able to get the sacral artery. And the spinal angiograms, I only did like couple a year. Even here, I was doing like 1 or 2 a year in the last 2 years. So they're very rare. And there's this update from in the Circulation Journal regarding using transradial. And those are some of the best practices. I covered all of them. I used all of them in my practice. And in the 2018 guidelines, radial axis is the standard approach for coronary angiography and PCI. And as you keep doing this, the technical failure goes down, and the procedural time also slowly goes down over time. Ultimately, the summary, use ultrasound guided, at least when you start out. And there are multiple obstacles. Be aware of the variants such as accessory radials or tight spasms. Left radial artery is an underused tool. And then think of obstacles from wrist to the neck. Once you go there, think about the obstacles from neck to the brain. And you need a good support, good proximal support of the ballast catheter and other things. You need to train your techs well as well. And hemostasis is not a very big issue with radial. You can just apply pressure and it should be fine. This was one of our paper. Well, I think I'm not in the paper because I graduated by that point. And I think 70 cases or 60 cases is the number needed once you become an expert, basically. So I stopped preparing groins for diagnostic angiograms. Like I showed before, the right snuff box and the left snuff box, that's the diagnostic. I don't even let the patients change their dress. They just go home within 1 hour or 2 hours after the procedure. Use ultrasound prior to starting. In some cases, in short stature females, I use the ultrasound to check the size of the radial and ulnar. In some cases, if the ulnar seems to be a little bigger, I just go through the ulnar with an ultrasound. And snuff box first always. That helps us save the radial. But if you're starting out, you just use radial artery first, and then slowly transition to snuff box. And yeah, just tell the nurses not to place the IV lines close to the right radial or right snuff box to leave the area for you. You don't want to be surprised in the, after the patient is prepped and draped, you don't want to be seeing an IV cannula over there. And I've been talking to multiple people who always call me for help, and I'm very happy to help you all for, if you need any assistance, if you want me to stay on the video during your case, I'll always be happy. All right. Any questions?
Thank you, Kalyan. Really exhaustive. I think we need a much more longer session.
Sure.
I think we'll plan something. We can plan something.
Sure. We can actually use the silicone models. And,
okay. We'll work on that now later.
Yeah, we can teach you the shaping of the catheters, and I'm speaking to Medtronic about it. We'll see if they can come up with the silicone model. We don't even need the whole body. We just need the arch and the yeah.
So we'll plan a workshop on this.
Sure, Dr. I'll be happy to come and help.
Yeah. I think it's almost 1 hour. I think we'll wind up for the day.
Sure.
Thank you, Kalyan. I'm extremely grateful to you. So we'll keep in touch now. Like we need your help, like in developing the radial program, because it's quite new to all the people who are trained in India. So it's only a matter of time and expertise and guidance to take up this. It's very, very attractive, especially for diagnostic, many things. Thank you. Yeah. Thank you. Bobby, you want to say something?
Excellent presentation. Fantastic. I think we have a lot to learn and a long way to go. Thank you very much for your insight.
Bobby works in, he's in Aster.
Got.
So I consider this just a beginning, no? Just an introduction.
Introduction, yeah.
We'll plan something.
Sure, Dr. All right, guys.
Okay, thank you.